Well, I do want to welcome everyone today. We have a lot of different agencies. So I'm Dr. Scott Maddalo, the medical director for the New York State Insurance Fund, or NYSIF. And today we have a webinar more targeted to medical providers of all types. Our presentation today is titled Coding Counts, talking about long COVID and ICD coding. It's an update for healthcare providers providing services to workers' compensation claimants. So I reference myself. I'm one of today's presenters. I'm the medical director for NYSIF. We also have Dr. James Tacci, the medical director for the New York State Workers Compensation Board, Dr. Flavio Casoy, medical director, and he is medical director for adult community services and managed care for the New York Office of Mental Health, often referred to as OMH. We have Dr. Eugene Heslin, the first deputy commissioner and chief medical officer for the New York State Department of Health, and often referred to as DOH. And in today's presentation and discussion, we're going to be talking about workers' compensation claims and the importance of using correct ICD diagnosis codes. I'm going to take an opportunity to highlight NYSIF's report on long COVID that we released earlier this year based on our workers' compensation claimants. And tying in with the ICD code, we're going to talk a little bit about some of the symptoms associated with long COVID. And of note, I do want to mention that none of this should really be taken as any sort of legal precedent or specific guidance, but this is more meant to be a holistic overview of what you might see with patients who have long COVID, and specifically highlighting the ICD code because we do think it's important that it's used properly. And I'm just going to highlight a little bit on the workers' compensation process and ICD codes. An overview of workers' compensation: it's insurance that provides medical treatment for work-related illness and injuries, wage replacement benefits if a work-related illness or injury prevents an employee from working, permanency benefits, or death benefit payable to an employee's survivors if the employee is fatally injured while working. When workers' compensation pays for medical treatment, such as treatment that's provided by healthcare providers, it has to be approved by the Workers' Compensation Board. There is a process for that, but it is pretty seamless. Information for healthcare providers that provide services to workers' compensation claimants is available on the New York Workers' Compensation Board website. And highlighting ICD codes, they were developed by the World Health Organization and adopted for use in billing in the United States by the U.S. Department of Health and Human Services. The current version uses the 10th revision of the International Statistical Classification of Diseases, or commonly referred to as ICD-10, and the Workers' Compensation Board adopted ICD-10 effective October 1st, 2015. And of course, it's very important to use the appropriate ICD-10 code when you're looking at any case. So specifically, we're talking about workers' compensation cases today, but anytime you see a patient, it's important to use the proper ICD-10 code. And I'm going to take a moment now to highlight NYSIF's long COVID report that was released earlier this year. We analyzed over 3,000 established COVID-19 workers' compensation claims. And what we were looking to understand was how many of our claimants developed long COVID, how long COVID affected various groups, and some of the most common symptoms that claimants suffer from. And we wanted to see what their experience was in everyday work life or returning to work. One of the things that we did have to contend with when producing a report is that long COVID does have a varying definitions depending on the agency you look at, but it is generally understood to mean the persistence or occurrence of symptoms for some time after initial COVID-19 infection. Public health authorities are considered long COVID to exist when, if we look at the World Health Organization, they would define it as symptoms that continue to develop 3 months after infection and last at least 2 months. The CDC, or Center for Disease Control and Prevention, defined as symptoms that are present for 4 or more weeks after infection. The National Institute of Health defines it as symptoms that last for months or longer. And again, it's more meant to be that symptoms are persistent for 4 weeks or more after the initial phase of infection, with the possibility of severe and life-threatening events even months or years after infection. That's from the U.S. Department of Health and Human Services and the National Research Action Plan. So at NYSIF, when we produced this report, we defined it as having one or both of the following. And it was either lost time for work of 60 days or more, or treatment duration of 60 days or more. So it didn't need to have both, but you did need to have one or the other. And we used this approach because we thought this sort of hybrid solution would allow us to catch more claimants and patients that seem to be suffering from long COVID, because some may have had more treatment and some may have missed more time for work, but were still seeking treatment while they went to work. And we applied this criteria to COVID-19 claims that we received from January 2020, so early on in the pandemic, to March 2022. During that period, for reference, NYSIF received over 89,000 workers' compensation claims, and of those claims, almost 5,800 were related to COVID-19. We did establish over 3,100 of those claims. And to look at the proportion of long COVID among our claimants, it's about 31%. So almost a third of the patients that had established COVID-19 claims met what our hybrid criteria of long COVID was. And if you look on the bottom right-hand corner of this slide, you'll see that 12.6% met the criteria based on the length of treatment. So again, that means that their length of treatment was 60 days or more. 10.7% met the criteria based on lost time from work. So again, that's 60 days or more of lost time. And 7.8% did meet the criteria because they either had treatment for greater than 60 days or lost time equal to or greater than 60 days.
Scott, may I ask a question?
Absolutely.
So in your definition of lost work time of 60 days or more, is that 60 work days or 60 calendar days? And the same for the treatment duration, just to be clear.
So we used 60 calendar days when we did
Thank
this.
you.
I think it was just a little more for contiguous reasons, but
Thank you.
no problem. And of the comorbidities that we identified with, I'm sorry, let me highlight some of the symptoms, and I will be highlighting Dr. Tacci, Dr. Heslin, Dr. Casoy just a little bit. A few of them do have clinics where they're seeing patients actively, but some of the most common symptoms that we saw for the claimants that we analyzed was shortness of breath, fatigue and weakness, amnesia or post-concussional type of symptoms. So more mental fogginess, depression, anxiety, post-traumatic stress disorder, chest pain, headaches, cough, fever, dizziness. So we found that a lot of our patients suffer one of these 10 in varying degrees. So the shortness of breath was the highest frequency category at 33%. And for comorbidities, the 5 most common comorbidities that we identify was chronic pulmonary disease. That is a wide category, but 30% of our claimants did have chronic pulmonary disease, 24% had hypertension, 21% cardiac arrhythmias and obesity, and 20% had underlying depression as well. And so now this is sort of where we're going to hopefully have into a fruitful discussion, but the long COVID ICD code was adopted by the CDC effective in October 2021, and the code specifically is U09.9, defined as post-COVID-19 condition unspecified. And when NYSIF looked at its long COVID claimants, we have 977 of them, but only 30 of them actually used this U code. Now, of course, it was effective as of October 2021, so that's about as partway through our data set, but even so, 30 total claimants is not really a very high percentage. In our mind, using the code could be very beneficial, though. It can improve the coordination of care. When patients are suffering from long COVID, it often requires a multidisciplinary approach, and using the code would help with that. It could certainly help with patients that are seeking Social Security disability benefits. Perhaps selfishly, it helps researchers understand the condition better, although I think long-term that would help everybody. Certainly, to know if the code should be used, you should be looking at risk factors and symptoms. And perhaps, Dr. Heslin, I can ask you to comment. I know you're still seeing patients, and I've listed some typical symptoms that patients may have with long COVID: difficulty breathing, cough, joint pain, post-exertional malaise. But would you be able to comment on what you're seeing or some of your colleagues might be seeing currently?
Yeah, thank you, Dr. Maddalo. The most common thing I see is just complete fatigue. People come in absolutely exhausted, and you might expect that, post-viral for a week or two. Many of them have cough initially, but that exhaustion is just pervasive. And they usually come in at the 1 to 2 month mark because they have really found that they just can't deal with it. It stops them from life activities. Um, it's interesting because when you look at the long COVID, there was an article published on October 29th out of Belgium in the International Journal of Infectious Disease. And it showed that even 1.5 years after having the start of long COVID, 50% of long COVID patients failed to improve. So you're dealing with a very significant population that has long-term events. And so it makes a difference. You have to really pay attention and have a high index of suspicion to make sure that you're catching these people, because it's often not the immediate event, but a somewhat remote event that you have to go back through their history to be able to pin this down.
Mm-hmm. Do you find that are you thinking about, I know the coding is very important. Are you using that long COVID code? I certainly would assume that you are, but how early in the process should a provider really, if it's a very low suspicion, should they be using it? Or is it they should have maybe some degree of certainty that that is what's happening and put that code down? Because once you put a code down, or you come from a clinical world, it's sometimes you get labeled with that, and maybe that is what's happening, maybe it's not, because every patient's experience is unique and what's happening for them is very unique. It's not necessarily one size fits all.
So it's interesting. When we first met a few months ago to start discussing this, I hadn't been using the code. As we talked about it and I thought about it, it's like, well, this is a new process. We don't actually have a lot of data on this, as in your previous slide, and we need to do a better job of understanding the entire process. So I started using the code. And I explained to people that, there are lots of codes, but this is something that can help you, because as symptoms continue, we need to make sure that you're treated appropriately. And we also need to make sure that as the research continues to advance in this, process, we're able to, get you better treatments. And, that makes a big difference.
It's certainly helpful to know that someone with your experience is still learning new stuff and trying to figure out when they could fit in some of these newer codes that are popping up. It's an ever-changing landscape is probably the best way to put it.
Well, what I'd say, Dr. Maddalo, is that there are lots of codes out there. But given that, half or more of our population in the United States has had COVID, and, 7.5% of them end up with long COVID, this is a significant issue that we're dealing with. And so we need to pay attention and make sure that we're doing this correctly.
Yeah. Well, so I'd like to turn to Dr. Casoy. I think there's been an underappreciation. Certainly from looking at our claimant database, 20% of our patients have baseline depression that could be mild or more severe. But a lot of people are suffering from some form. It's a broad category, but mental health is a big problem, and mental illness is a bigger problem when patients who seem to have gotten an acute COVID infection, maybe their shortness of breath got better, maybe their chest pain is not a huge issue to them, but they're still suffering. I've heard anecdotally, a lot of people just feel like they're quote unquote out of it. Maybe that's the best way. That's how they colloquially will describe it to me. I just don't feel like myself. I can't focus that well. And so I guess I'd like to defer and see what your experience has been in your clinic and some of the colleagues that you're talking with on an everyday basis.
Yeah, sure. And Dr. Maddalo, thanks so much for inviting me and organizing this webinar. And I agree completely with Dr. Heslin too, and what he was saying. So COVID, an infectious disease that sort of touches many systems, has many symptoms, right, certainly can impact the brain, right? I mean, it goes through, we think that, the brain cells can also harbor viruses. And then, of course, the inflammation can cause serious disruptions to the circuits in, the part of the brain that regulates emotions or thoughts or cognitions or learning. And it can take a long time for these sort of circuits to repair themselves, even long after the infection resolves, because the inflammatory processes might go longer. So one thing to think about is the worse the infection, the higher the risk of worse sort of neurological or psychiatric or cognitive sort of sequelae, right? So so that's an important thing. But even people with mild illness, mild COVID illness, can still have sort of long, lingering sort of changes in their mood and their anxiety and their ability to think. Individuals with more serious illness, who maybe are in the hospital, for an infection or in an ICU, can have even sort of worse symptoms, maybe even things that, psychoses, sort of hearing voices or having beliefs that are clearly false, but no matter what you tell the person, they will still have that belief. These are known as delusions.
Yeah.
And then aside from the infection, right, COVID was a horrifically stressful time. Being in an ICU can be traumatizing and leaves a lot of people with PTSD, fearing for your life if you get sick, even separate from the impact of the infection on your brain, can lead you to have PTSD. If you lost loved ones, or if loved ones got really sick, that could be a traumatic experience that leads to PTSD. And then everything else that happened in society, right? All of the other anxieties. My practice, at the beginning of, before the pandemic, I had to have a side practice where most of my patients had mild illness with relatively straightforward medication regimens, and I did psychotherapy. Throughout the pandemic, even for the individuals who had not yet gotten sick, their psychiatric conditions worsened. They required more time from me, more involved medication regimens and so forth. So across the board, the mental health of the country went down, and many people's mental illness worsened. And just to say, we're still sort of figuring out what's going to happen in the future. There's still people being hospitalized with COVID. There's still people sort of developing PTSD and all of the other negative consequences that come from this. And there's a lot we have to learn. We have to be very humble in what we know. But I think, for clinicians to begin recognizing that worsened psychiatric symptoms or new psychiatric symptoms might be a result of COVID, even if the COVID illness was mild, is really important to keep that front in mind, because if we don't think about it, we don't do anything about it. So I really applaud this effort, and I encourage folks to look at the SAMHSA report that's on your slide. It's also very interesting, very informative, and a great resource.
Yeah. Thank you so much, Dr. Casoy. Dr. Heslin, did you
I
have a
was just
comment?
going to say, adding to Dr. Casoy, who's 100% right, as a family medicine doc, we always have to remember that we have to, listen with compassion, and we have to ask questions to start the conversation. Because sometimes people don't even realize that they have. And obviously, he sees a sicker mental health population than I probably do. But a large part of family medicine and primary care is dealing with, mental health issues, and particularly stress-related issues. So, to my family medicine and internal medicine colleagues, you have to have that index of suspicion, and then you have to be willing to start the conversation. And these are time-consuming conversations, but are important conversations.
Yeah, absolutely. And I would certainly echo Dr. Casoy mentioned that certainly if you're hospitalized or in an ICU, you could suffer from that illness itself, but obviously it's traumatic just being in an ICU. We did find in our report, I didn't want to put everything on the slides. I would encourage anyone to take a look at our downloadable PDF, but we found that if someone was hospitalized and they had COVID, they certainly had a much higher risk of having long COVID. We didn't necessarily grade the severity right off the bat, but your likelihood was very high if you were hospitalized, because it showed a much more severe acute infection, at least. To your point, Dr. Heslin, your family medicine doctor, I did pain management. I was an anesthesiologist for a bit. I worked in an orthopedic surgery group. I think for our orthopedic colleagues out there, this is not exactly something that they should ignore. If they think it's something that's happening, they could even start the conversation. But certainly, I think that's where this code helps. If they think this is what's happening, they can put this ICD code down and they can give them a referral to Dr. Casoy, one of his colleagues, because then maybe they can have a deeper conversation and figure out how they can help them a bit more. I think just acknowledging that could be very helpful to patients, even if it's not the whole journey. If it's step one, that's still better than no steps. And I think a lot of patients feel frustrated that they feel like maybe some of the providers just aren't there for them because they don't fully understand what's happening. And I've listed some resources here from all of our respective departments, but I do want to bring in Dr. Tacci. I know you represent the Workers' Compensation Board, and I think there's been some confusion. I think we've even experienced a little confusion when I first started at NYSIF about COVID claims and how they actually are established. Again, this is not really a legal precedent or any specific guidance, but it was very confusing because some people thought they had to have a COVID test. So I'd actually like to ask you a specific question. Do you have to have a COVID test to establish a claim with the compensation board, or is that required anymore, or was it ever required?
Sure, Scott, and thanks for the question, and thank you also for the sort of the disclaimer about not creating any legal precedent or the like. Unlike doctors Heslin and Casoy, I work with attorneys and judges all day, right? They want to make sure that we stick to the medical topics and that we don't, again, give out either legal advice or opinions or set legal precedent. And you are correct. There has been some confusion out there. And what I would say is that the PCR testing remains the gold standard. It remains the gold standard clinically. It also remains the gold standard informationally. It's administered by a healthcare professional. It's patient specific. It's date and time stamped. It's analyzed at a laboratory. So all of those things make it ideal for inclusion in a workers' compensation claim. That said, the board has realized that there may be a lot of claimants out there who have not had PCR testing done, either because of their own personal circumstances precluding them from being able to have it performed. It may be the practice patterns of their healthcare providers in terms of ordering the tests or performing the tests, et cetera. And there's a whole, there's several reasons why people might not have it done. And the board, if a patient and their healthcare provider believes the patient has COVID, and they and their healthcare provider believe that COVID is causally related to their work, the board doesn't want that absence of a PCR test to be perceived as an absolute barrier to filing a claim. So the patient and their primary care provider, or whomever it is that's treating them, can file a claim. The provider can state his or her opinion as to why they believe the person has COVID, which may be antigen testing. It may be, whatever their medical rationale is, and they can provide their medical opinion as to why the COVID is causally related to the individual's work, and those claims will be considered. So you're correct that there has been some confusion out there. PCR testing remains the gold standard, but if you have a bona fide medical opinion from your healthcare provider that you have COVID and it's work related, you shouldn't feel precluded from filing a claim and having it considered.
Yeah. I did pain management. I focus a lot of my care on patients who had orthopedic kind of injuries. But I think there's this misconception that in workers' compensation, it's all musculoskeletal. It's all joint pain or fracture or sprain or tendon tear. I guess I would certainly stress, and maybe I can defer to you for some of the resources, but workers' compensation claims, it's literally anything that happens while they're in their course of employment. So I know a lot of people know about the medical treatment guidelines for back, knee, shoulder, foot, ankle kind of injuries. Are there other resources that the New York Workers' Compensation Board has for sort of process like mental health or lung disease or something like that.
Sure, and perceptions are very often based in reality, and the majority of workers' compensation claims are indeed musculoskeletal, right? So that's that perception is well founded in reality, but there's a significant percentage of claims that are in other body parts, body systems, pathologies, et cetera, particularly in the areas of pulmonary, psychiatric, dermatologic, traumatic brain injuries, et cetera. So I would refer people to, in terms of the breadth of clinical pathologies that we see, I would refer people to our website that you've been kind enough to share on the slide for all of the medical treatment guidelines. There's 16 medical treatment guidelines addressing different body parts, different pathologies, et cetera. And those are generally addressing either body systems or body parts with multiple diagnoses contained within each guideline. As a selfless plug, our providers can also receive free CME credits for doing the training on those guidelines. We have 16 guidelines at 3 credits apiece, so you can get 48 credits if you sat down to do all of them.
That's great.
And I would also say, specifically with respect to COVID, which is our topic today, there's board pages on our webpage devoted to COVID, whether it's in the form of a subject number that was issued or just informational pages on our website. We've done numerous patient / claimant webinars related to workers' comp claims and COVID, and we've tried to include on almost all of our provider webinars at least a few slides talking about COVID as well. And those are all, I don't know how many we've done over the past year. We've done them at least every other month, if not monthly, and those are all recorded on our website for folks to view as well.
Wonderful. Well, Dr. Heslin, Dr. Casoy, I don't know if you want to make a little bit of a plug. I know there's a lot of resources on both of your respective departments' websites as well. So if you want to make a plug, now's the time.
I'm just going to say, look at the website. It's extensive and it is constantly updated. I would just also say that many times people who come in for our topic today, long COVID, don't come in right away. And so some of them do home self-tests and others. So you have to really listen to the story and make sure you have the story correct, especially if you think it's something that is going to fall into the compensation, workers' compensation area. So that's my only plug, is high into suspicion, and make sure that you are being a good, clinician scientist.
And Dr. Casoy, any parting comments you can give to us?
I agree with what's been said, and I just want to say that there's a lot more to learn about this, and we don't know how much of this will change as more research comes in, and there's a lot to learn.
Yeah, absolutely. Well, I do want to thank everyone for taking time to help us with this webinar. So again, we've had Dr. Eugene Heslin, Dr. Flavio Casoy, and Dr. James Tacci. I'm Dr. Scott Maddalo. Thank you for taking the time to listen, and I wish you the best.
Take care, everyone.
Thank you.